Good morning. Thank you for allowing me to share our program in the Philippines. It was a 27-hour travel to get me here. Probably it's the farthest among all the participants. Anyway, I belong to the University of the Philippines, Manila School of Health Sciences. It's an innovative program where we say we train our health workers to stay in the country. We don't train our health workers for export. Our country for so long had been training health workers using a Western-based hospital-oriented model, which actually resulted in our graduates leaving the country. 63% from our university, which is a national university, left the country. And for those who stayed, about 15% only, they were mal-distributed. They were mostly concentrated in urban areas. In short, we trained our health professionals in the Philippines to take care of the needs of other countries rather than our own. So our greatest challenge for us was how to develop health workers who were not only technically competent, but more importantly, socially competent, socially conscious, who would go back and return and serve in the rural communities where they were needed most. The challenge also was to train them with competencies that were suited to their workplace and eventually equitably distribute them in the different areas of our country, especially in areas of need. So what we did, the University of the Philippines did, we engaged in joint education and health systems planning with the Academies, the Ministry of Health, and the communities in order to develop an innovative curriculum that would develop this kind of health worker who would address the country's needs. So this is our innovative curriculum. It's a step-ladder curriculum. It's a community-based, competency-based curriculum that trains the midwife, the nurse, and the physician into one continuous and sequential curriculum. The students are recruited by the communities themselves. They nominate the scholars who enter the program. They support the students through the program. They may either finish any level of the program, but they start all with midwifery, and they may leave at any point depending on community need, and also depending on community need, they may come back to the program. In between program levels, we have what we call the service leave, wherein the students have to go back, the graduates have to go back to the communities that nominated them and sponsor them and render health and community development services in these areas. And that's also a requirement for licensure. So, okay, so how did we develop the competencies? The competencies are actually driven towards local needs, and two major components were used as the basis for deriving the competencies. One was the community. So these were the health challenges in the burdens of disease in local communities of the Philippines, as well as the social determinants of health. And on the other hand, the healthcare system, the structure of our healthcare system, which has the midwife as the frontliner. And we also, there's a portion there, it says availability and health workforce requirement, because in many areas of our country, there's only either a midwife, there's a nurse, there's no physician. So we have to teach our health professionals to multitask. They would have, like, they would should know how to deliver babies also in areas where there's no midwife or there's no physician. So they have to assume tasks of midwives, nurses, and physicians at the same time. So that was also an important component that became part of the step-ladder curriculum. And we also had to marry the rules and regulations of midwifery practice, nursing practice, and medical practice in developing the curriculum in our country. So what competencies do we develop our graduates in? We have 5 competency areas that are threaded throughout the curriculum of midwifery, nursing, and medicine. So we call it a 5-star health professional. Primarily, they're trained as healthcare providers, either as midwives, nurses, or physicians. We train them to become community organizers and mobilizers to organize the communities for health action. Then they would have to be running programs and services, supervising health and auxiliary personnel in the community. So we train them also as health service and program managers. We give them skills in research. We give them skills as trainers and educators also at the same time. These are threaded throughout the competency. This is just an example of what happens. Like, for example, the midwives would have to learn how to do health education to individuals and communities. When they get to nursing, they do disease surveillance, epidemiologic investigations. When they go to nurse medicine, it's gradated. Each one builds on the other. Like midwifery, they focus on taking care of children and childbearing mothers. When they go into nursing, they have to go into include psychiatry, medical surgical nursing, and other health problems. But when they get to medicine, they're taught as a clinician. So what happens is a graduate may finish the whole program. So they're a nurse, midwife, a nurse, and a physician, or a health team rolled into one person, or they can only finish one program depending on the need of the community that sent them. And so it gives them a better understanding and appreciation of the roles and contributions of the other health personnel in the team when they come out of it, and they also learn together. What's next? It's not moving. So what skill sets do we teach our students? The star, of course. So the small circles at the edge of the stars represent the 5 competency areas: healthcare provider, community organizer and mobilizer, a health service and program manager, trainer, educator, and research. But we felt that over and above these different competencies, threaded into each of these competency areas, communication is a very important component. They should be taught how to dialogue with the community. And then there's also advocacy, which is an important component. And we have cultural competence. We, in the Philippines, sometimes treatment is associated with cause of the disease. So if it's a supernatural cause, then they go to a traditional healer, So we have to have cultural competence also. And decision-making is a very important component in any of those skills. And mentioned a while ago was values, which is also very important because, as you said, our graduates in the Philippines had so much economic values that sent them outside of the country. We wanted them to stay and serve in the Philippines. So there's very important in our training is service orientation. We talk all the time about service excellence, especially in communities of dire need. We talk about equity issues. They're expounding on the students' commitment to serve the communities that sent them. We tell them your community is waiting for you. And then we talk about compassion in service and social accountability in our training of our students. One thing very important that out of all of these competencies, we felt that the core competency our students should learn is bridging leadership. Because if we look at the 6 building blocks for health of the WHO, the center is actually local, it's actually leadership and governance. If one is able to develop skills of leadership and governance, then the health professional will be able to coordinate all the other 6 building blocks of health. So the framework that we use for teaching leadership and governance to our students is what we call the Bridging Leadership Framework, which has 3 components: ownership, co-ownership, and co-creation. So what happens in these 3? We said the bridging leader should be very important about a bridging leader, and bridging leadership that we teach our students as a core competency is self-awareness. They should be aware of their own values, and they should have a strong sense of purpose, which is to help their communities. And they should also have a strong sense of knowing what the health divides are in the community. And having done this, create a personal vision for themselves. And this personal vision should be brought on to the next phase, which is co-ownership. In co-ownership, we teach the students to be able to convene multi-stakeholders from different sectors. We teach them how to do, instead of individual cases, we teach them multi-stakeholder processes. So they learn how to do systems thinking. They learn how to do dialogue for them to be able to bring other stakeholders to the table, such that the personal vision of the health professional and the community leaders and local chief executives, which we're also training, becomes a shared and common vision. So when it becomes a shared and common vision of the community, the students are able to move on into the last phase of the framework, which is known as co-ownership. In co-ownership, they're able to change new institutional, build new institutional arrangements. What we want them to learn how to do is think out of the box, network and collaborate with other people, other stakeholders in the community, whether health or non-health, in order to be able to improve health outcomes. We're actually focusing, by the way, we're also doing this not only with our students, we're also doing this with local chief executives and local health leaders whom we're also training in this framework. And for the several cohorts that we have had success in bringing down maternal mortality rates as well as infant mortality rates by training the local chief executives, who most of are not doctors. So these are just some of the competencies that we train them. As you said, in co-ownership, in ownership, there must be self-mastery, understanding of one's purpose and values. We need to, they must understand the health challenges. There must be visioning. They must learn how to create a vision. Then in ownership, they must learn how to work in teams. And when they work in teams, they must learn how to do dialogue very well, manage conflict among health professionals as well as in the community and as well as coach. Co-creation requires competences of creativity, innovation, networking, partnership, as well as resource mobilization. So the basic messages we would like to share from our program is that there is a need definitely to train more health professionals to meet the shortage, but not necessarily of the same kind. And secondly, education of health professionals should be community-based. It should be competency-driven and interprofessional. So our students learn midwifery nursing separately in the classroom, but when they go to the communities, we have one training community where we have a nurse, midwifery student, we have a nursing student, and a medical student in one community. So they learn to work together. The medical students can exercise supervision over the nursing over the midwifery students. So it's basically interprofessional, and it's very community engaged. Basically from day one, they already start in the community. Whereas in other schools, medical students would only spend 2 months out of their entire medical education in school. Our students spend 1.5 years of internship in the community for medicine only, but they've already had experience in the community as midwives and as nurses. And there is a need in our training to emphasize quality and relevance. So we train the right health workers with the right skills suited to the future health workplace that they're going into. And it is very important that there should be interaction and joint planning mechanisms between the academe, the health system, and the local governments if we're able to improve health outcomes in our communities. Thank you and good morning. I hope I hit my 5-minute challenge.